Good evening. My name is Peter Petros, and I will be talking to you today about the integral theory with a colorectal perspective. The integral theory began in 1990 as the integral theory of female urinary incontinence, which said that stress and urge incontinence mainly derive for different reasons from laxity in the vagina or its supporting ligaments, a result of an altered collagen. In one word, the integral theory is very simple. Repair the structure, the ligaments, and you will restore the function. That's it. Repair the structure, the ligaments, and you will restore the function. By 1997, the integral theory had evolved into the integral system, a holistic diagnostic and management system for prolapse, bladder, bowel, and pain problems caused by lax ligaments and cured by repair of these ligaments. So the first thing is a validated integral theory questionnaire. The answers are transferred to a diagnostic algorithm which tells you which ligaments or fascias have been damaged. Then you need to examine the patient, examine the vagina to confirm the zone of damage, and finally what we call simulated operations. By supporting a specific ligament, if you look down here, a hemostat at mid-urethra will stop the urine leaking when they cough. For the uterosacral ligaments, you put a speculum in, and that supports the uterosacral ligaments down the back. And relief of the urge or the pain or the urine loss on coughing will confirm that a particular ligament has been damaged. The first and most important discovery was that three oppositely acting reflex muscle forces, here forwards pubococcygeus, backwards levator plate, downwards conjoint longitudinal muscle of the anus, contract against suspensory ligaments. These two contract against the uterosacral, this one contracts against the pubourethral. There it is there. So they contract against suspensory ligaments to open and close the urethra and the anus, and to control urgency. They do this by stretching the organs, the bladder and the vagina and the rectum in opposite directions to control the stretch receptors here and here. In other words, by stretching and controlling the stretch receptors, they control the urge to urinate and defecate. Now, as you will see, almost all the bladder, bowel and pain and prolapse problems and solutions to them, that is cure, evolve from this diagram. This is the most important diagram in the integral theory. Let me repeat, three opposite muscle forces contract against uterosacral ligaments down the back, pubourethral ligament in the front to open and close the bladder and the anorectum. The second discovery was pathogenesis. Pathogenesis is all about collagen defects from childbirth or age, weakening the ligaments to cause bladder bowel prolapse, incontinence and retention, urinary or fecal retention. Now, let's go down here and have a look. There is the vagina, the rectum, bladder. Now, as the head, this is the circle, as it comes down, it can damage the uterosacral ligaments to cause uterine prolapse or anterorectal wall intussusception here, or further down, it can damage the cardinal ligament to cause cystocele, the bladder. Further down, it can damage the perineal body to cause low rectocele or descending perineal syndrome. And here, it can damage the pubourethral ligament to cause urinary stress incontinence. The third discovery was a new surgical principle from experimental animals. So a tape harnesses the wound reaction to create new collagen to repair damaged ligaments. for instance, a midurethral and posterior slings. If you look over here, here is the vulva of the animal, the vagina, the bladder, the uterus, and the tape caused, which was removed at 6 to 12 weeks, creates very good collagenous neoligaments. The fourth discovery that symptoms, bladder, bowel, pain, prolapse, dysfunctions are caused by loose ligaments, pubourethral here, cardinal ligament here, uterosacral here, arcus tendineus here, going to the ischial spine, and perineal body here. And if you can repair every one of these ligaments by tapes, pubourethral, stress incontinence, midurethral sling, posterior sling, cardinal ligament sling, perineal body sling. Now this is a cadaveric specimen, it's my own work. I've got a knife and just cut it out from the pelvic brim. The bladder had been, and the vagina had been cut off and the uterus at bladder neck. Now, you will see the forward muscle is pubococcygeus. Here it is. And right here you can see the pubourethral ligament. It contracts against the pubourethral ligament. The pubococcygeus muscle goes around, joins with the other side, and the iliococcygeus to form the levator plate. And if you look here, you can see the levator plate is actually inserted into the rectum. So that's the backward muscle, pulls the rectum back. And the puborectalis muscle. Now here is the puborectalis muscle. It tucks underneath the pubococcygeus and goes medial to attach to the symphysis. It goes around the rectum, does not insert in the rectum. And there's a conjoint longitudinal muscle of the anus. This takes fibers from the levator plate and the pubococcygeus, and it inserts into the external anal sphincter, and it pulls down the levator plate, angulates it, and pulls down the rectum, the vagina, and the bladder during straining and, in fact, evacuation. Now I'm going to correlate the anatomy with the X-ray findings. Here is an X-ray at rest. You will see the bladder, the urethra, the vagina, the rectum, and the levator plate. Now what happens when a patient coughs or strains? The first thing that happens is that these two muscles, forwards, backwards, downwards, act. So the forward muscle pulls against the pubourethral ligament here, pulls against the pubourethral ligament, and closes the distal urethra. The backward muscle, as you can see here, tensions the rectum. Look at that. There was the rectum. It tensions it. It tensions the vagina. And this allows the downward muscle, the longitudinal muscle of the anus, this one, to pull down on the levator plate, angulate it, and close off the urethra and the anorectal angle. Now, if you look here in the yellow, that is the puborectalis muscle. And you can see that anorectal closure occurs when, if this contracts forwards, remember, it's behind the rectum, it's behind the rectum, the anus and the rectum here. So when that contracts forwards, then the backward muscles rotate the rectum around the puborectalis to close off the anorectal angle. And that is, in fact, the closure mechanism for the rectum. Now, I'm going to show you all this on ultrasound, but first let me show where everything is. There's the pubic symphysis, there's the bladder, there is the urethra. Here is the anterior and posterior vaginal wall, AP. Here is the anus, you can see that quite clearly, and the rectum coming up here, and you can see the levator plate inserting into the rectum directly. Now, what we're going to see, there's the pubourethral ligament coming in white to the mid-urethra. All right, now I want you to watch what happens here. This is the distal urethra, and what happens here. Let's start it. This transperineal ultrasound demonstrates
the three opposite directional forces.
So we're going to see that forward muscle here closing off the distal urethra. Look at that. That's the pubococcygeus. It pulls against the pubourethral ligament, closes it here. Now next you're going to see two movements, back and down. They curve together. I want you to watch the bladder neck. Look at that. It is closed. It is closed. You see that it tensions the vagina, like I told you. Tensions it. And look, the levator plate moves backwards. Watch it now. It moves back and down. It gets pulled down by the longitudinal muscle of the anus. Look at that. It gets pulled down, down, down. And you can see it also moves back. So the three directional movements close the urethra. Later on, I'm going to show you this again and show you how it closes the rectum. We saw from the ultrasound that the urethra is closed here by the forward muscle and the bladder neck is closed by the backward and downward muscle. This is how it works. There's the pubourethral ligament. Now, as you saw, this forward muscle closes the urethra and tensions the vagina here. The next thing that happens is this levator plate, you saw it pulling back, it tensions the vagina and the urethra, and this next muscle downward rotates and closes the bladder neck. But look here, there's a pubourethral ligament, which is parallel to the pubourethral. It inserts into the arc of Gilvinae, so that, and this is very firm, so that the downward muscle then rotates and closes it off here. Now, because we've got opposite muscles, you need elasticity in the bladder neck area, and that is called the zone of critical elasticity. So when those of you who are gynecologists or anybody, you never cut the bladder. You always must keep the bladder neck free. If you create scar tissue here, then you can unbalance the system and these muscles will pull open the vagina. So in summary, forward muscle closes the distal urethra, back muscles stretch the vagina and the urethra and rotate and close the bladder neck. And this is the zone of critical elasticity. It must be left elastic. The mechanism for micturition is virtually the same as closure. Just look at it this way. If this muscle relaxes, then these two muscles pull open the posterior wall of urethra, open it out, the bladder contracts, and the urine is expelled. Let's talk about the control mechanisms. The control mechanisms are controlled by the cortex. As the bladder fills, as the rectum fills, the hydrostatic pressure of the urine or the feces activate the stretch receptors and they send afferents to the brain. If it's not convenient, the brain sends a signal to the muscles and they stretch in opposite directions, and this supports the stretch receptors from below, supports the column of urine, supports the feces, and the efferents decrease. The problem occurs because these muscles pull against ligaments. Hit this one against pubourethral. These ones pull against the uterosacral. So if the uterosacral ligaments are loose, then the muscle force weakens. They can't stretch in opposite directions. They can't prevent as many afferents going up here, and the patient can get urge incontinence of urine or feces. As we said earlier, how do you fix it? Repair the structure, the ligaments, and you will restore the function. Integral theory is very, very simple. Repair the structure and you will restore the function. The mechanics for anorectal closure are very similar to the bladder. A little bit different. Puborectalis muscle contracts, levator plate and LMA stretch here the rectovaginal fascia, and they stretch the rectum backwards and rotate it downwards to close the anorectal angle. And if the patient wants to defecate, if this puborectalis muscle relaxes, then when they pull backwards and downwards, the posterior rectal wall gets pulled down to this broken line. It opens out the anorectal canal, decreases the resistance, and the defecation goes out. Now let's have a look at the x-rays. Here it is resting. There's the rectum, there's the vagina, there's the levator plate, and there's the uterosacral ligament. When it's time to closure, there's the puborectalis muscle. You see it's around the rectum. It holds the wall of the rectum tightly, and then these backwards and downwards stretch the rectum like that. They stretch it and rotate it downwards to close the anorectal angle. If these ligaments are loose, then this closure mechanism doesn't work so well, and they can leak feces. That's fecal incontinence. So very briefly, I'm going to show you a video, but very briefly, for defecation, puborectalis contracts. These pull open the posterior wall of the anorectum, decrease the resistance, and allow defecation to occur. Now, this has got audio to it.
What will follow is defecating proctogram. The purpose of this still X-ray is to identify the different anatomical structures which you will be seeing in the video sequence. R is the rectum. It has had radiopaque dye injected into it. The red square identifies the anorectal angle. To the right, you will see the levator plate muscle. It has had 10 mils of radiopaque dye injected into it. On the superior surface is a white line which is almost horizontal, and that identifies the superior surface of the levator plate. Just below, you will see a yellow circle. This has been placed around a space in the levator plate. This space will be seen to move according to the particular muscle contraction. In squeezing, it will move upwards and forwards. In straining and defecation, it will move backwards and downwards.
So squeezing pulls everything upwards.
Squeezing, all the structures are pulled upwards and forwards. Note how incredibly elastic the structures are and how much they move. So the rectum and the anorectal angle is made more acute, and the levator plate itself is lifted forward. This is probably due to the contraction of the puborectalis, which lies underneath the levator plate. This next segment is the description of straining. The patient has fecal incontinence, and you will see that the sequence opens with a very tentative attempt to strain. Finally, the patient strains. The tip of the levator plate is pulled downwards, and you can see that there is some feces exiting from the anus. In defecation, the muscle movements are similar to what is seen in straining. That is, that the anterior border of the levator plate is pulled down. But in this case, you will see that there is an opening out of the anorectal angle due to relaxation of the puborectalis. Also notice how the anterior surface of the anus is pulled forwards to open out the lower end of the canal. So we see that the upper end of the canal is pulled open by relaxation of the puborectalis, and the lower end of the canal, the anterior surface of the anus, is pulled forwards by the forward contraction of the pubococcygeus muscle.
See, it's being pulled forwards. The anterior wall of the anus has been pulled forwards, and the anorectal angle is flattened. It's been pulled down by the levator plate. You can see the levator plate attached actually to the posterior wall of the rectum. You can see it, and it's pulling it down. As the longitudinal muscle of the anus pulls down the tip of the levator plate, it opens out the posterior wall of rectum, and you can see down here, this will pull forwards to facilitate the exit of feces from the anus. Then it's going forward. That's a pubococcygeus muscle pulling forward. Pathogenesis is due to collagen damage to the ligaments and connective tissue. So childbirth and age weaken the ligaments and fascia, and therefore the contractile force of the three reflex muscles which contract against them. Now, if you look here, the head dilates the cervix to 10 centimeters. It stretches the cardinal ligament, it stretches the uterosacals, and it can dislocate the vagina attachment to the cervix. As the head comes out, it can damage the pubourethral ligament here, but also it can dislocate the pubococcygeus muscle attachment to the pubic symphysis. Again, repair the structure and you will restore the function. Now, this is the pictorial diagnostic algorithm, and in the integral theory, the symptoms tell you which ligament has been damaged. So you know from the patient's history immediately what symptoms have been damaged. What I'm going to do is correlate this with this, which I've talked to you about. So there are three automatic sections in the pelvic floor. There are the front ligaments, pubourethral, that goes to the bladder neck, middle ligaments, bladder neck to the cervix, and posterior uterosacral to the anus. Okay, so stress incontinence, this ligament here it is, there's the circle. It's damaged the pubourethral ligament, so it cannot control, so that when the patient coughs, the muscles here are weak. This ligament cannot control the opening of the urethra, so you get stress incontinence. Look at the next one, 4, perineal body. Now, perineal body, down here, you can get erectocele and descending perineal syndrome. Now, cystocele up here. Now, cystocele has 2 ligaments, the cardinal here in front of the uterus and the arcus tendineus. So if this ligament is weak or damaged, then this whole thing rotates down and you can get a cystocele. There are 2 symptoms here. Obviously, urgency because the vagina is loose, you can't stretch it, and abnormal emptying because this cannot be opened. But the most important ligament is the uterosacral. Here, if it's damaged, you can get uterine prolapse or intussusception. It's important for emptying of the bladder and the bowel. If it's damaged, the muscles can't stretch the bladder or the rectum to control the stretch receptors, frequency and urgency, nocturia. And I'll deal with chronic pelvic pain in a minute. That's a different thing, but it's caused by loose uterosacral ligaments. I'm going to take you briefly through this. as the head comes through the birth canal, it's highly unlikely that you're only going to get stress incontinence. You're going to get problems everywhere. You could get problems, sister seals, you're going to get problems down here, problems down here. And the next slide will show us exactly what happens when you take a full history for all the symptoms. This is from Professor Gershon's work. He had 198 patients that came along with chronic pelvic pain, and when he examined them, they had some degree of apical prolapse. Now, Professor Pescatori, a colorectal surgeon, described the Pescatori iceberg. Now, remember I showed you that when the head comes down, it's unlikely to cause just damage in one area. It's going to damage everything. And Professor Pescatori found, and he described the Pescatori iceberg, that patients complain of one major symptom only. In other words, so you've got to look for all these. They're under the surface. Now, if you use the Integral Theory System questionnaire, it's the only questionnaire which specifically seeks out every one of these questions. Now, all the other questionnaires from the International Continence Society, they're either fecal or bladder or pain or quality of life. The ITSQ, there are 35 questions, 1.5 pages, and you will get all of these. Now, Professor Gershon found, now remember, they said, "Doctor, I've got chronic pelvic pain." Then he asked, you've got to ask about these other symptoms. 55 had urge incontinence, 198. 56 had fecal incontinence. 68 had bladder emptying problems. 127 had frequency. 66 had stress incontinence. 63 had nocturia. 59 had ODS. And 44 had high residual urines. Remember, they came in with chronic pelvic pain. So always remember the Pescatori iceberg. Whatever the patient comes into you with, you must ask about these other symptoms. The Pescatori iceberg. I'm going to talk to you about chronic pelvic pain. Now, in 1996, I described 28 patients where I plicated the uterosacral ligaments and cured the chronic pelvic pain. This was native ligament plication. At 3 months, 85% cure. At 12 months, 70%. Now, the visceral plexus, if you look over here, the ganglion of Frankenhauser, T11 to L2, and the sagral plexus, S234, are supported in brown by the uterosacral ligaments. Look over here, in red, the visceral plexus are supported by the uterosacral ligaments. If these are loose, then the force of gravity, especially when the patient stands up, can stimulate the visceral plexus here, and the patient, it sends afferent impulses up to the brain here, and the patient is deceived in thinking that the pain comes from a distal organ. Now, you can test for this. If you have a patient with urgency or chronic pelvic pain, if you put a speculum in gently, you can mechanically support the uterosacral ligaments, and it will, in 70 to 80% of the time, improve the symptoms of pain and urgency. So this is preoperative proof of uterosacral pain and urge causation. The speculum support of the uterosacral ligaments, which are weakened by childbirth and age, reduces pain and urge to confirm uterosacral damage. That's the pathogenesis. Now, pain, gravity here, stimulates the visceral plexus. Impulses to the brain are interpreted as coming from the end organ. So the patient will say, "I've got vulvodynia," or "I've got pain on intercourse," "I've got pain in the lower abdomen," or if you palpate them, Paraurethrally, they can have severe pain. So, and if you repair the uterosacral ligaments, you can actually repair the pain and the urgency. Now, chronic pelvic pain occurs in 15 to 20% of all women. So this is a very good test, a speculum test. You examine them with a full bladder. If they've got urgency, and you put the speculum in, within 3 or 4 seconds, they will tell you 70% of the time that the urge has improved and so has the pain. It's called the speculum test, and it validates the causation of pain from the uterosacral ligaments. I'm going to talk about pathogenesis and cure of anterior rectal intussusception. If you look down here, the uterosacral ligaments are attached to the lateral wall of the rectum here. Childbirth and age weakens the ligaments, which elongate. You look here, it elongates, and you can get uterine prolapse and enterocele. Now, because the levator plate has lengthened, it loses contractile force. It cannot stretch. It cannot pull the rectum backwards. Remember I showed you that the levator plate is attached to the back wall of the rectum. It can't pull it backwards to tension it. And the anterior rectal wall prolapses inwards. And surgery, you shorten and reinforce the uterosacral ligaments. Professor Abendstein from Austria was the first man to do this. He showed that if you do a posterior sling, you shorten and reinforce the uterosacral ligaments. He showed radiologically with proctograms that he cured the anterior rectal wall intussusception. I want you to look over here on the right. Now, here's the uterosacral ligaments. If they lengthen, remember the uterosacral ligaments attach to the rectovaginal fascia here, and if they're loose, the rectovaginal fascia, which separates the vagina from the rectum, becomes loose, and the anterior wall of the rectum prolapses in. So what Albenstein did, he put a sling in here to shorten and pull back the uterosacral ligament, and that restored the anatomy, restored the levator plate contractility. So you don't need to put a mesh here, just fix up the ligaments. We're hoping to make that one of the projects of the ISA of our association, where we repair the ligaments laparoscopically with number 2 polyester, and the polyester hopefully will induce sufficient collagen to make it a permanent repair, as we do with the posterior. Now, this is some work that we've been doing in the engineering school, where I'm an adjunct professor in engineering, and we've been working on the resistance to flow. It's quite complex, as Ahmed will tell you later on, but very briefly, the rectum is actively opened by these muscles, as is the urethra, and it shows that if the ligaments are loose here, you can't open either the rectum or the urethra. So let's look here. If you can't open it, and the bladder and the rectum has to push through an unopened anus or urethra, you need a very high pressure to get a decent flow. But if you can open it externally, for instance here, with the bladder, if you can open it to 6 millimeters, you only need 20 centimeters of water. If you can't open it, you need 180. And it's the same with the rectum. So very briefly, it's all to do with the exponential nature of the resistance. Exponentially, inversely to the 4th power of the radius. Now, if you've got uterine prolapse, you can see here it's supported by the uterosacral ligaments posteriorly, but the cardinal ligaments anteriorly. So you've got to repair both. This is a 60-second video. So you've got to repair the uterosacral and cardinal. This is a 4th degree prolapse. It's going to amputate the cervix, and this is done under local anaesthetic. There's transverse incision, and she's going laterally just above the ischial spine. She's going to put a tape in there into the obturator fascia on the right side, and now a tunnel here, and on the same side, 2 centimeters above the ischial spine and forward, putting in the tape. It's like tacking it on, tightening it, and you'll see that already the prolapse has gone back. This is a posterior vaginal wall, 1 centimeter below the cervix, and the same thing. Made a tunnel next to the ligament on the left side, right side, and now the left side. There we are, and tightening it up, shortening and tightening the ligament. You see that's a wonderful result, and we expect to do this laparoscopically. It's one of our projects to repair the uterosacral ligaments exactly like that, but from above, by shortening it and reinforcing it to repair anterior rectal wall intussusception, and of course for the gynecologist, sacrocolpopexy is about the descending perineal syndrome. Now, I'll show you the anatomy here. The perineal body is actually attached to the behind the upper 2/3 and lower third of the ischial spine. And it's actually the deep transversus perineal ligament. It's actually a ligament. It's quite thick. It's about at least 1 centimeter wide. I've done dissections on this. But what happens during childbirth, the perineal body is either stretched or broken, and these deep transverse perineal ligaments are stretched laterally, and the mucosa of the rectum can actually penetrate. Quite often you find that the serosal layer is broken. And I'm going to show you the video here with the video of
repair by making a channel along through the actual deep transversus perineal, right through, going behind the descending ramus between the upper 2/3 and the lower third. We then get the TFS and we actually penetrate like this. We penetrate the deep transversus perineal. Bring it out there, release it, and then, so this is what we call a descending perineal syndrome. The deep transversus perineal are more vertical now instead of horizontal. So we put a tape in on one side, attaching it behind the descending ramus of the pubis, and now we've got one on this side, and as we tighten it, then the whole system becomes more horizontal. You can see I'm pulling it, and it's becoming horizontal. So we're going to do the perineal body now. T-incision. Three forceps. The rectum here is quite adherent to the vagina, and it's been damaged. Space. Always dissect under counter tension. There's the space in there. Number 1 vehicle, please. I've got it here. So with the number 1 vehicle, you go in and you identify the perineal body.
There it is there, artery forceps. There it is, quite separate from the rectum. Some fascia from the wall of the rectum, and we have to make a space between the vagina. We have to make a space between that. There's the space. So I've pulled over the rectum and I dig in here. It's quite lateral. There's the perineal body, it's quite lateral here. There's the rectum there. I'm digging in with the needle. Pulling it out there. I've got my finger in the rectum. I've got an Alice forceps on the perineal body, and I will now go into the perineal body towards the insertion of the deep transversus perineate. Here is the descending branch of the ramus. So I have to go in this direction because that's where the main support of the perineal body is posteriorly. So I make a hole in the perineal body, like this. Well away, it's well away from the, I can feel the pubic bone here. It's well away from the rectum. There it is there. I can take my finger out now. Now when we're putting the TFS in, we always do it under tension, like this. Like this. Take it out, Pete. Remove the scissors. We're pushing it in until we feel a resistance. And then we remove it. Wait 10 seconds and you pull it like that, and we put an artery forceps on the lateral side. So this section is towards, there's the descending ramus, there, so that's the direction. It's well clear of the rectum. Go into the hole, and counter pressure, we take the forceps out because we don't want to be pulling against ourselves. Yep. Counter pressure on the handle, and we pull until we feel a resistance. When you feel a resistance, you stop and pull out. If you pull too hard, now that's a bit loose, you can see this.
So what we do there, if you look down here, we put a tape in there, and we pulled it together, and the perineal body was brought to the midline, and the rectus seal went down. So that's the cure of descending perineal syndrome and ODS. At 12 months, 27 out of 30 patients reported normal defecation, and the median of obstructive defecation score was significantly reduced to 4. There were 3 complications: a surface tape, a recurrence of rectus seal, and foreign body abscess, caused by the same ligaments and cured by repair thereof. So this was from Dr. Inui's work. So prolapse, He got 92% cure, urgency 93, nocturia 72, frequency 90. This is at 12 months. 92% dragging pain and 88% fecal incontinence. These are astounding figures. I was never able to achieve them as good as this. This is from Professor Gershon, who had 198 patients with pelvic pain. These are the incidents after the surgery. Frequency 26 out of 127, bladder difficulties 80, so 50% there. Stress incontinence about 93%, obstructive defecation about 80%, urge incontinence again about 80%, and residual urine he cured about 50%. So quite good figures. The final one is from a multi-center study, 611 patients. Chronic pelvic pain, 77% cure, nocturia 68, urge 85, frequency 83, fecal incontinence 65, and apical prolapse 90. This is data at 12 months. Thank you very much. So the take-home message is, if you repair the structure, the ligaments, you will restore the function. Integral theory. Thank you very much.